Uh, yes, hopefully we'll be able to get this all set up very momentarily. And I am, oh, um, yeah, hopefully that is sharing. Is that right? Can you see it? Okay,
Yeah.
perfect. I'm currently on my organization's Wi-Fi, so we generally can get through a Zoom conversation and with a PowerPoint presentation. But just in case, just so let me know if all of a sudden you stop seeing it. But yeah, so grateful for the opportunity to speak to you guys. Um, yes, my name's Callan Fockele. I use she, her pronouns, and I'm the senior medical lead out here in Seattle, King County, Washington State, for the Opioid Recovery and Care Access, or ORCA program. And I'm going to be talking about our new model for post-overdose care. Yeah, a couple of disclosures. I don't have any relevant personal financial relationships to disclose, but our program is supported by public funding, city, county, and state sources in particular. And we also have some federal funding, of course, through Medicaid, and then also some research funding, particularly through NIDA. So who is this person? Who am I? Who's like talking to you? And I appreciate that there are a bunch of learners on this call, so I thought I might just talk a little bit about my background, and I'm happy to discuss any of that type of stuff, the journey that took me to the work that I'm doing now, in addition, of course, to the clinical work. But yeah, I grew up in Virginia, went to medical school in California, and I did residency at the UW Medicine Department of Emergency Medicine. And then day two residency, I was like, what am I going to do with my life? I can't become a community ED doc. So it was the long journey to try to figure out what that plan B was. And a part of that process was doing a population health research fellowship for 2 years in the Department of Emergency Medicine at UW at the University of Washington. And then I was working clinically in some permanent supportive housing sites as the Harborview UW Medicine physician working in those clinical sites, and really enjoyed that work. Love doing home visits, doing outreach, and realized that I just had a huge gap in my knowledge around addiction medicine. So I went back and did addiction medicine fellowship at UW. I didn't get far. And then during this process, I started doing research with expert advisors on drug use, or REDO, which is a group of people who are community engaged researchers, people with expertise because of their lived and living experience of drug use, partnering with academically trained researchers at the University of Washington. And I was so excited to start working with them and learning from them. And just a major shout out because they're going to kind of feature in the evolution of some of the work that I'm going to talk about in a moment. And then ended up working clinically as an attending at Harborview Medical Center, which is our large county hospital here in King County, which is where Seattle is located, which also serves the WWAMI region, so the Washington, Alaska, Montana, and Idaho area. That's our level 1 trauma center for that region, and also serves the vulnerable populations locally and across the 5-state region, or 4-state region, really. But and then I moved from the academic center at the University of Washington to a nonprofit organization called the Downtown Emergency Services Center, DSC. And this is the building where I currently work in, and I'll talk a little bit more about that in a moment. So the DSC is a nonprofit organization that's mission is to help people with complex needs of homelessness, substance use disorders, and serious mental illness achieve their highest potential for health and well-being through comprehensive services, treatment, and housing. Um, it is a huge organization. There are over 2,000 people who work here, and it's kind of like three nonprofits all smushed together. There's a housing nonprofit. So that's we're actually landlords for thousands of people. We have 20 permanent supportive housing sites in addition to 3 emergency housing shelters. There's what we think of as clinical, so kind of our behavioral health programming that has this kind of acronym soup. There's SAGE, HOST, PACT, COACH, lots of acronyms where there are these multidisciplinary healthcare teams that either do mobile crisis outreach or longitudinal case management and mental health support, particularly SCD counseling. And then the third kind of nonprofit that's part of all this is the medical side of things, primarily psychiatric and addiction medicine services. So that's where I sit, is in the medical side of things, and that's where the program that I work in, ORCA, is situated. But just importantly, it's part of a much larger umbrella of work that's happening in this space. So, a little bit of a agenda of what we're going to talk about. I think no surprise to anyone in the audience, but we're going to talk a little bit about the opioid crisis. But I'm going to kind of zoom into the community that I work in. And then we're going to talk about a need for low barrier and outreach-based medications for opioid use disorder services, a need for a safe landing zone, particularly for people post-overdose, talk about pre-hospital buprenorphine development, particularly in our community, and then a development of a scalable method to start MOUD, or those medications for opioid use disorder. So I think it's just important to also talk about the why, like the why all of us get interested and excited about this work. And my why for if I were to like kind of pinpoint a time where my journey to where I am now kind of started for me was when I was a second year resident in emergency medicine at Harborview, that county hospital here in King County. And I was a second year resident, and this was like July 2017. So it was I just became a second year. And I had received sign out on patients from my another senior resident who had been around the block and like really knew the emergency department. And this person said, I got an easy one for you. There's this person who was around my age, in his 30s, suspected an opioid overdose. At the time in 2017, it was heroin. So a suspected heroin overdose. Found down, has been metabolizing, in quotes, in the emergency department for hours, waking up, and I went above and beyond. This is the other senior resident kind of saying, like, I kind of went above and beyond, got the Narcan kit. The Narcan kit's at bedside, got a printout, 1-800 number at the bedside. All you have to do is watch this person eat a turkey sandwich and walk out the door. I said, oh, okay, awesome. I can do that. I can watch them eat the turkey sandwich. So I did, watch them walk out the door with their discharge paperwork. And 6 hours later, in our emergency department, the senior residents would carry a pager. And that pager would go off every time medics were calling to receive permission to do anything in the field. So I run to our medic room, pick up the radio, and on the other line, Medic One, which is our paramedics in our area, are saying, hey, doc, we're currently 45 minutes into CPR on a patient who was found down, suspected opioid overdose. They're still asystolic. We want to cease efforts. And I said, sure, yeah, that sounds appropriate. It sounds like you did everything you could do. And he said, hey, doc, before you hang up the phone, just wanted to let you know this person still has a medical record band on. And I think you guys know where this is going, but this person looks like they're just discharged from the hospital. And it was the person I had just discharged 6 hours before. And, these things happen all the time, right? Like people we see, something really terrible happens to them immediately afterwards. And I think the reason why this case in particular really rocked me was like I was expecting to like be brought into the principal's office. I was expecting this case to be like QI'd. Like we really need to talk through like what happened for this case to have ended up this way. But none of that happened. And the reason why is because that was the gold standard at the time. Um, that a person who presents to the emergency department after an overdose may receive zero care, may just get a turkey sandwich, and that was the standard. And that just felt horrible to me, and that just really didn't sit right. And it was definitely activating in some other things that I'm going to talk about in a little bit. But around this time, I think this paper actually came out in like 2020 or so, but it was looking at a cohort of patients, very similar to the patient I was just describing, in like the 20 teens, so around the same time period, looking at the 1 year mortality of patients who had a non-fatal opioid overdose and make it to the emergency department, and looking at how many people died at a year. This was looking in the state of Massachusetts. And they found that 5.5% of those folks died at a year, and not necessarily from opioid overdose, but from a myriad of things and anything, just like had they died at a year. And 5.5%, maybe that like our gut check is like, yeah, that sounds about right. But when we think about like other conditions, so for those like younger people who have a STEMI, status post PCI. So those who kind of go like lights and sirens to the hospital, activate the cath lab. Cardiologist meets them at the door. They get admitted to the hospital. They do cardiac therapy, all those things. Their all-cause mortality at a year is about 7%. So comparable, but yet the standard of care just seems so wildly different. And what seems really interesting about this study is they looked at when did people die, and it was really that 48 hours after an overdose event was the highest peak. So something about patients in that like subsequent days after an overdose event. And I think we can speculate why that might be the case, like experiencing withdrawal, using the same substances that led to that initial overdose. But there seems like a particularly high risk period of time. And now we know that since the era of fentanyl, that the all-cause mortality at a year is much higher, so likely more like 10 to 15% compared to this cohort back in the 20 teens. So zooming into King County, where I work, we have this really incredible dashboard that looks at week to week, what are some of the trends in our community. So this dashboard, this is a screenshot of EMS responses, which are high, like hundreds of people a week are being engaged with our emergency medical services with a suspected opioid overdose. And at the bottom level, you can see the emergency department visits. And just to recognize, like, yes, these are high numbers. Um, but what seems particularly critical, though, is that those numbers don't mirror or like they aren't the same. So there's something that's happening where there's like EMS responding to a suspected opioid overdose, but yet not all those people make it to the emergency department. And in an internal report here in King County, this was now a number of years ago in 2023, it looked like about a third of those who've had a suspected opioid overdose don't make it to, aren't transported to the emergency department. So they either decline transport or something happens where they don't make it to definitive care. And internally in Seattle, Seattle is the largest city in our county. In Seattle, we think that percentage is over 50%, at least at the time. And probably similar to many places in the country, there are a lot of people dying from overdoses, particularly in our community, fentanyl. And compared to the East Coast, fentanyl hit the West Coast in my community much later. So it was really 2023 is when we peaked. There are 1,300, over 1,300 people who died in our county from a suspected overdose during that year. And something that seems not novel, but just like worth calling out in our community too, is that the largest percentage of people dying, this like purple over on the right, are those who are using opioids and stimulants. And there's certainly a subset of folks there who are like really only using stimulants and have accidental exposure to opioids. But it's fairly well documented in my community that there's a lot of comorbid use of people using stimulants and opioids. And here, as and I'm sure elsewhere in the country, there's a disproportionate impact of overdose deaths among those with a history of homelessness. So more than 50% of those who died in our county were either living in permanent supportive housing, living outside in temporary shelter, or unhoused. So just calling out that the population who I think definitely a mission population for the organization that you guys are a part of is disproportionately impacted and why we should care. And it looks like there's an upcoming conversation about opioid use disorder that you guys will probably all have experience with. But just to call out the diagnosis of opioid use disorder is not hard. Opioid use disorder is the kind of physiologic properties, which are down at the bottom. So tolerance needing more and more to have the same effect, withdrawal symptoms, and then these kind of categories of when there's a psychosocial impact of use that creates a use disorder. So they can fall into the categories of impaired control, social impairment, and risky use. And it's important to note that it's not just the physiologic properties that need to be checked, but there has to be some sort of psychosocial impact for there to be a diagnosis of opioid use disorder to occur. But I would argue this diagnosis can be made very easily, particularly in the setting of opioid overdose. Like if someone has a suspected opioid overdose, they're experiencing withdrawal, check withdrawal. They use larger amounts than intended. Um, they they were able to, they used in a physically hazardous situation. If you get any history about like cravings or continued use despite physical or psychological harm, like you've basically made a diagnosis of moderate to severe opioid use disorder already. So spend a few minutes talking to someone after an overdose event, and you've checked that box, which opens up a lot of doors for how we can help support and treat folks. And you may be familiar with this, but the COWS scale, so our COWS score, so the clinical opiate withdrawal scale. And I won't go into the details of all of this, but there are both objective and subjective signs and symptoms of withdrawal that are easy to calculate using MD Calc or some other type of application. And why this is important, in particularly in the overdose setting, is that after someone has received naloxone, depending on the pharmacology, like the administration and the formulation of that naloxone, person when that medication kind of peaks, you can kind of march out someone's CAL score over time. So someone's CAL score can initially be pretty low, but if you check it every couple minutes, you can see it march up to much higher once that naloxone has been completely absorbed and peaked in their system, which again opens a lot of doors for us to be able to treat with medications. So just to flag that scale. Again, not to belabor this because I think it seems like it's coming up, and I'm sure I'm speaking to an audience that's really well versed in this, but um, I just like to think about kind of opioid receptors or cups kind of throughout our body, and opioids bind to that receptor or cup. So full opioids, like fentanyl, fully fill up that cup. The bummer about fentanyl is it's super short acting. It wears off, sometimes like within an hour and a half or 2 hours. So people have to kind of keep redosing that cup in order to fill it up. And, that means like sometimes dosing again, like an hour and a half to 2 hours a day. Because once that cup is completely full up, people can generally feel well, but when that substance starts wearing off, emptying that cup, people start feeling withdrawal, cravings, and other symptoms. So some of the medications that are used to kind of combat and treat opioid use disorder work on that receptor or cup. So methadone, full opioid agonist, completely fills up that cup, helps with withdrawal and cravings. But on the flip side, it's a full opioid agonist so that in higher amounts or when using other sedating substances can cause some of the same side effects as a full opioids like fentanyl. So respiratory depression, sedation, those kinds of issues. Um, Other bummer about methadone is that it's federally regulated in a way that it makes it much more complicated for people to start on the medication and engage in care, meaning that often people have to come to an opioid treatment program or methadone clinic daily for a prolonged period of time, particularly while we're kind of escalating people's doses. And because of the unique pharmacology of methadone, people often start off really low, so they start at lower doses and they slowly increase it over time. So sometimes it can take weeks or months for people to get on that therapeutic dose to fully fill up that cup. And then I'm not going to talk about naltrexone because of the medications we have to offer for opioid use disorder, it actually does not impact positively mortality or morbidity. So I often like don't even like put that on the table as an option for a lot of folks. But happy to explore that more after the presentation if people are interested. But I do want to focus in on buprenorphine. So we have these receptors or cups, and buprenorphine is a partial opioid agonist. So it binds to that receptor cup, but it fills it up just partially, so kind of halfway up. What's awesome about that is that it helps with withdrawal and cravings, but it doesn't cause some of the negative side effects that full opioids like methadone can cause because there's a ceiling effect. Um, uh, and so when people have use of other substances, other things, it still reduces the risk of overdose, respiratory depression, sedation for those who are not opioid naive. A con though is that buprenorphine is like super strong and like really binds to that receptor and won't let go, which in some ways is awesome because like if it's really bound on there and won't let go, when other opioids like fentanyl try to bind onto it, it can't. So it reduces the risk of overdose significantly. But what's a bummer about this is if someone has fentanyl or other opioids in their system and buprenorphine started too quickly, um, it will actually cause some phenomenon called precipitated withdrawal, where someone will feel really sick. If you can imagine, you're like on the 10th floor of a building when you're using fentanyl, and you jump down to the fifth floor to that partial opioid agonist to buprenorphine, that drop from the 10th floor to the fifth floor really abruptly can cause significant symptoms, nausea, vomiting, diarrhea, a cow scale that's really, really high. So what's really tricky about fentanyl is that although fentanyl is in our bloodstream, and clears our bloodstream like within an hour and a half to 2 hours for some folks. That makes people feel super sick, like super symptomatic with withdrawal. Fentanyl sticks around our fatty tissue and muscle for hours, days, which makes it really complicated to get started on buprenorphine because you're like on the 10th floor for days, and you need to get to that fifth floor. So, how do you do that in a way that makes people not feel so sick? And I think to really emphasize that point is that, particularly for those experiencing homelessness and maybe don't have access to, um, a bathroom, a shower, someone to help support them when they're feeling sick, like it can be really complicated to like get someone on this medication with the risk of this like phenomenon of precipitated withdrawal as a real worry of like causing precipitated withdrawal and then folks not wanting to get started on these medications in the future. So fentanyl's really just changed the landscape, made it much more complicated to get people started. So like I mentioned before, some barriers to treatment are this higher risk of precipitated withdrawal with fentanyl when folks are like missing appointments and they have difficulty engaging in care. When people are experiencing homelessness, like storing medications is often difficult. Historically, we asked folks to like stop using fentanyl for like days before starting on the medicine. That's also impossible, like I mentioned before, if you don't have access to a bathroom, water, someone to like care for you during that period of time. And then just like a history of like not being able to get started on medications that for X, Y, and Z reason, and the stigma of trying to get access to care in environments that may not be friendly or supportive of you. So, kind of bringing it all back to some work that was happening prior to the program that I'm now part of. The DSC had the historical remnant of what is currently happening called the Opioid Treatment Network, or OTN program, which is doing a lot of novel work over the last few years that was the precursor to the work that we're currently doing now. So just talk a little bit about the process that really opened up the doors for a different type of care for patients interested in medications for opioid use disorder, or MOUD. So a couple of years ago, there was really opening the door when it came to long-acting injectable buprenorphine. Um, Sublocade had been on the market, is a two monthly formulations, but there is this new, hot off the press, long-acting injectable medication called Brixadi, which had both weekly and monthly formulations. And what was super cool about this was that there are different peaks and troughs of all these medications depending on the dose and formulation. So, like historically, one way to get started on these medications, it was kind of like this bifurcation. One would either be like you go into withdrawal and you do a high dose start, which is that like feeling sick for like hours to days, and then take a high dose start, or do teeny tiny doses of oral or sublingual buprenorphine over time, over the course of days to weeks. But if you don't have access to watch, you don't have access to like a safe place to store your medications, it's really tricky to do that like low dose start. So the team, the Opioid Treatment Network, or OTN team, I was like thinking about how do we get people started on the injection, particularly our population, which is primarily those experiencing homelessness and people living in permanent supportive housing and shelter. And wow, the injection seems so awesome. Like we use a lot of LAI antipsychotics, long-acting injectable antipsychotics. Like that's super helpful for our patient population. We should really figure out how to use long-acting injectable buprenorphine. But the FDA insert that came in all the packages were like, you have to be stable on sublingual buprenorphine for a period of time, a week, before getting started on the injection. And that was next to impossible for our populations to start doing. So that really took that, if you followed the FDA advice, like kind of off the table. But looking at like all the pharmacology, all these injections, some really amazing folks, including Carson Bell, who's featured in this photo, were like, what if we use these injections kind of like this low dose start? So we used like a little baby dose of the injection and just see what happened. And so we were talking to a client, a patient, about this, and this person was trying to get on the sublingual buprenorphine and unsuccessful, unsuccessful. And they're like, just give me the shot. Just try the Brixadi 8. We're like, are you sure that the FDA says we shouldn't do that? And the person was like, no, I really want to try. So they got the Brixadi 8 and they didn't have much withdrawal, which is super interesting. So just to put a pause on there and kind of go into a deep dive, like here are like the millions of ways to get started on buprenorphine to try to avoid the risk of precipitated withdrawal. There's like the low dose sublingual start. There's the withdrawal first, so go into withdrawal, take a high dose start. There's like giving naloxone, right? Like your receptor's full of fentanyl. Naloxone like knocks off all those receptors or cups, and that opioid receptor cup is empty. Perfect time to get buprenorphine on there. We tried that. It was horrible. Patients hated it. And then there's all these injections. Like, could you go straight to this monthly injection? We tried that. It was also really terrible to experience because it was like too high, too fast. Um, there were like patches, buprenorphine patches that people could use, but we had a difficult time getting that covered by insurance. So we tried all of them and then we experimented and we came up with I mean this happened before I was there, but they came up with this process to like kind of slowly incrementally start people on the injection series. um, so on day one they would get a Brixadi 8, so the baby dose. On the second day they get a Brixadi 16, the medium dose. On day three they get the monthly injection. And then after that, 24 hours after that injection has peaked, they could supplement with sublingual buprenorphine. So if you can imagine that receptor cup, you're on the 10th floor, you're trying to get to the fifth floor. On the first day, you get to the first floor. On the second day, you get to the third floor. And then on the third day, you get to the fifth floor. But if you can imagine, if you're on the first floor on day one, that receptor or cup is like super empty still. So you really have to continue using full opioid agonists to still fully fill up that cup so people don't feel so sick. Um, what we like to say is like protracted withdrawal. It's not precipitated withdrawal. It's not the medicine causing it. It's just like that receptor cup is just too empty. So you need to continue to use full opioid agonists. So we would counsel folks to continue using, not to change their use patterns during this 3-day process because they still needed those full opioids during this process, and then doing the injection series, which is interesting and unique in that folks could be smoking fentanyl immediately prior to coming in, getting an injection, encouraged to like not change their use during the process. And how did this work? It was really through our pharmacy partners. This is the only way. And these are like our incredible pharmacy partners called Kelly Ross Pharmacy that was able to help us navigate all the insurance and other issues that came up with these things. And then we also got funding through our Washington State Healthcare Authority to receive money to help with a buy and build model, which meant that we purchased a bunch of the injections through this grant, and then we would give it to those with active Medicaid, knowing that we could get reimbursed for that medication. So those with active Medicaid and receiving care at our clinic could receive stock. And those who had private insurance, dual enrollment, and/or receiving outreach-based care would receive pharmacy-delivered medications through our partners at Kelly Ross. And we published on this, or at least the first couple months of this care, just to describe like that this seemed like really cool. We wanted to share it. So this was looking at October of 2024. 95 individuals met inclusion criteria, meaning that they were interested in getting on medications and open to getting the injection and had OUD. Most were kind of middle-aged men. 79% of whom were experiencing homelessness or living in permanent supportive housing. Of the 95 patients, 85 or 90% started the protocol. 75% eventually completed the protocol, and 64% received a second monthly long-acting injectable. So showing some sort of retention. And then similar to like other types of protocols that were happening at the same time, they're published around the same time, were like a low dose sublingual start that showed more like retention at like the 15 to 20% level. And they marked retention, I believe, with just filling the second prescription. So very exciting. And just to show like how that looked in the clinic. In August of 2024, before this was started, there were about 25 new enrollees each month. And then looking at like when we started doing these injections, it just kind of skyrocketed like 2 to 3 times the number. And over time, that just kind of like exponential growth, like people are kind of coming out of the woodworks, or like people are bringing their like friends and neighbors and partners and siblings and children, parents to the clinic or being outreached in order to get this care, which is super cool and exciting to be a part of. Um, so also it kind of became untenable because we had like scattered provider time, a couple of nurses, and a peer who was instrumental to this work. But it was like there are too many patients. So it became like a really incredible timing for us to receive funding through city, county, and state funds to expand the work into what eventually became the ORCA program or the Opioid Recovery and Care Access. So still part of the DSC, but just expanded. Um, and this work, kind of in parallel to all the clinical innovation that was happening at the DSC OTN team, there was some research and other work that was happening that demonstrated like a need for expansion and innovation. So that group Redo, the Research with Expert Advisors in Drug Use, back in 2021 or so, started doing some qualitative work, really a large around some like state legislation that was happening in our state about drug possession. It really prompted a desire to like want to improve high risk touch points, whether they be in the law enforcement, overdose response, EMS, mobile crisis responders. Like, how do we improve care for those who are receiving or who experienced an overdose or like at high risk of experiencing an overdose? So there's some qualitative work that was happening at the time with people living living experience, people on the front lines, and it was really out of that work that Public Health Seattle King County, our public health department, asked Redo to create a strategic plan for EMS and overdose care. So there's some qualitative work, there's some work groups around with some key stakeholders about like how do we go from here? Like how do we improve this? Particularly because December 2022, when this was released, this was right at the cusp of when we peaked. Of overdoses in our community, particularly related to fentanyl. And there were tons of recommendations, as you can imagine. But the two things that kind of floated up to the top, one was pre-hospital buprenorphine, and the second was a 24/7 ED diversion center. And pre-hospital buprenorphine, which I'll talk about in a minute, but just to kind of highlight this fact, like fentanyl fully filling up the cup, overdose, like fentanyl's like overflowing the cup. It's causing the respiratory depression, sedation, potentially overdose death. Naloxone is an opioid antagonist, so knocks off that fentanyl, so the opioid receptor cup is completely open and free, screaming for opioids because this person's experiencing withdrawal cravings. That's actually the perfect time for buprenorphine to be plopped right on that receptor cup to partially fill up that opioid receptor and help with withdrawal cravings. So pre-hospital buprenorphine was happening elsewhere in the country, and there was excitement to potentially create a similar program here. And then what we were hearing also from folks, especially those with lived and living experience, of like, man, the emergency department was a terrible place to be. Don't want to go back. Could you like create some alternate destination that could like help address my needs in a way that felt right for me? So out of this work, and kind of in parallel to this work, the University of Washington's Addictions, Drug, and Alcohol Institute applied for a NIDA grant to help create a 24/7 ED diversion center and evaluate it. So just a little bit more of a jump into this pre-hospital buprenorphine world. There's this post-overdose response team, which was part of the Seattle Fire Department's mobile integrated health team. So this kind of community emergency medical service team that was really created in the spirit of helping serve high utilizers of the 911 system and historically had been vulnerable adults, primarily those experiencing homelessness. But by executive order from our mayor at the time, there's a decision to like create a subset of this team called the post-overdose response team. And that team was a case manager at our city paired with a firefighter to be able to respond in real time to overdoses. And importantly, that firefighter is an EMT basic, so not a paramedic, but a basic life support EMT basic. And there weren't a whole lot of other tools in the toolkit at the time, and they were going to a lot of overdose calls. But it felt like, man, I really wish I could do something more than just, not just, but like in addition to providing trauma-informed care. And again, at that time, there were a lot of like talk about doing pre-hospital buprenorphine. Like, wouldn't this be so amazing if we could get medication into the mouths of people who are symptomatic out in the field? And maybe that would help improve their care and also maybe reduce our mortality because buprenorphine kind of amazingly works 48 hours, which, as we remember, is like that high risk period of time after an overdose where we saw that peak of people dying. So Seattle brought pre-hospital buprenorphine to the advanced life support or ALS level, meaning paramedics could do it. And then because of our kind of novel system here in Seattle, ALS providers weren't making it to the scene a lot of the times for those after an overdose event for a variety of reasons. So we became the first city in the country to be able to administer it at the BLS or basic life support EMT basic level, which was very exciting. So this was now, and this is old data now, but you could see in the blue line is our ALS providers at the beginning, like our overdose response team needed to be there basically for all of them. And then that red line was when our Health 99 or our post-overdose response team started carrying buprenorphine and it's just skyrocketed. And this like number of 175 and 143 is much higher today. So just case in point, there was a person in one of our DSC permanent supportive housing buildings, unfortunately, who had an overdose event, and 911 was called. And this overdose event happened kind of far away from where the Health 99 or post-overdose response team is located, like on a good day, like 15, 20 minutes lights and sirens to get there. Um, this person had an overdose event. The more local fire department had responded to the scene, and the person had said, I'm fine. Don't worry about me. I don't need anything. So they left and they kind of code greened the call saying, like, we don't need any more help here. Whereas the Health 99 team was like, nah, we're on our way. We're going to keep going. So they got there, checked in with the front desk. The front desk directed them to their room, knocked on the door. By the time they opened the door, the person, now it's been like 15 or 20 minutes after the event when which they received naloxone, and they were super symptomatic, having significant withdrawal symptoms. So the Health 99 team was able to give buprenorphine out in the field in that moment. The person felt a lot better. They're able to have a conversation about their goals and hopes. And the person had disclosed, I was on buprenorphine and it had been a couple weeks where I just got out of my prescription. This was super helpful for me. I would like to be on it. I'd actually like to be on the injection. And in that moment, the Health 99 team reached out to my team, and we just so happened to have an injection for this person. We were able to go and administer that medication hours after their overdose event, which was super cool. And it really just like highlighted that like this is so cool because the system works in this particular setting, but we really need a safe landing zone for overdose survivors more generally in our community. And we just need lower barrier access points to medications for opioid use disorder. So that finally gets us to ORCA. So ORCA is our ORCA program, and there's two components. There's the ORCA Center, which provides 24/7 post-overdose care and also same-day MOUD access. And our other part is our patient outreach division, ORCA pod team, which brings care to clients in DSC, permanent supportive housing, emergency shelters. And our goal is to create spaces to meet people where they are. So kind of the two ways to get into the front door at the ORCA Center is that overdose survivors can come in 24/7 and stay for up to 24 hours. We've served more than 500 overdose survivors at this point, and about 70% of those come directly from the field from emergency medical services, so being diverted before making it to the emergency department. And then our other population that we serve are those interested in MOUD, and we have walk-in services from 9 a.m. to 11 p.m. every day of the week, every day of the year, and folks can get started on sublingual or long-acting injectable buprenorphine or methadone. So Yeah, so we have buprenorphine sublingual in stock, so we can offer that to everyone. And these long-acting injectable buprenorphine injections that we have available for those with active Medicaid in that moment. Otherwise, we get them pharmacy delivered, and we can get pharmacy delivered medication 6 days a week. We also use the 72-hour rule. We're not an opioid treatment program or methadone clinic, but we can use the 72-hour rule in order to start someone on methadone and connect them to care. Um, and we have an opioid treatment program or methadone clinic, care navigator here Monday through Friday, and a provider here 2 days a week in order to help support that linkage to care. So this is an ORCA center looking really snazzy before we actually opened. We opened September of 2025, so it's been almost a year since we've been open. And now there are currently like curtains that separate the different recliners. But this is a spot where someone can recover from an overdose, start medications, um, have access to shower, snacks, and laundry. We have a provider and nurse here 24/7, medical assistants during the day, what we call non-clinical milieu specialists at night, and provide education and connection to care. So folks may arrive either from the fire department and our other crisis team, or be a self-referral walk-in. They come to the front desk when the rest of our clinic, because we're one clinic embedded in a much larger clinic called the Downtown Behavioral Health Clinic, which provides drop-in services, showers, hot breakfast, behavioral health services, connection to case management. When the rest of the clinic is open Monday through Friday, 9 to 5, they can check in with the front desk. After hours, there's a buzzer that they can press. Um, One of our staff members greets the person, brings them back. We do an assessment and can offer them medications in that moment. And for those who are overdose survivors, we're constantly thinking about discharge planning. And with our partnership with one of the emergency shelters in the same block, we manage 5 beds for 5 days for those initiating on medications and for opioid use disorder in particular, or need further care coordination. So we can like find and outreach them the same day. And our ORCA pod, our outreach team, are providers, nurses, and peers who bring care directly to people, meeting them where they are. And they provide medications and also support, including peers groups that are happening weekly. And just a very cool thing that also occurs in our system is overdose response tracking. So for those who are DSC clients who had an overdose event, either in community or at one of our clinical or housing sites, we log this in our system and it alerts on the interface, so that we, as the ORCA team and our substance use disorder professional team that works in housing, can assign someone to outreach them within 48 hours and offer them services, including medications and peer support and SUD counseling. And we just have a ton of partnerships that really run the gamut of government, community, and academic partners like Harvard V Medical Center. And we've been open since September, and unfortunately, our EHR doesn't make it super easy to like pull some of the data. But looking back until May, we've had our ORCA Center and Pod total have had close to 8,000 encounters. Uh, Currently, I know at least this number is like now over 500 overdose admissions, over 700 walk-in intakes for medications for opioid use disorder, over 700 new MOUD starts, and most of which end up getting on the monthly long-acting injectable. So just to think about a case, so this was a person who I got to know when I first started, now like before ORCA opened, like 12, 15 months ago. It was a person with a long history of homelessness, severe mental illness, engaged with our OTN and then ORCA team, was pretty regularly prescribed sublingual buprenorphine, but it was a little hard to like figure out if this person was engaged, like actually taking the medication or what that experience was like. Um, they were eventually linked with another behavioral health program within our system called HOST, which did intensive outreach. They were able to identify a serious infection. This person was hospitalized, had surgery, and I ended up coming out and engaging with our services in order to like do wound care And, over the course of these months and months of getting to know this person, they had multiple overdose events, which we actually didn't know about. But they received pre-hospital buprenorphine from that Special Health 99 team 3 times. 2 times they were lost to follow-up or there wasn't a connection that was made. But that third time, ORCA Center was open. So they were taken to ORCA and they eventually received a monthly injection to provide that person protection for 30 days or longer, really. And just kind of remarkably, the host program had been working on housing with this individual, and they signed a lease for permanent supportive housing that same day. Another example for the outreach that we do, there was a couple living in a tiny house village. They were seen by an ORCA nurse in the field for a start. They had both tried a number of times, but doing that low dose sublingual start, but had been unsuccessful. And they started the 3 day long acting injectable and were able to get on the monthly and were able to work in on like housing. So they got into supportive housing and reconnecting to family and looking at employment. And for them, which was super important, was just significantly reducing their use. And what was also wild was that more than 5 intakes came from that community because they saw their friends and colleagues like getting through the injection series, but also like feeling a lot better. And that was like such an impactful moment for others to say, like, yes, I want that too. And that kind of like people coming out of the woodwork and like interested in the medication drove the fire department locally to do a pop-up event in a neighborhood, really one park in particular where there is a hot spot for overdose events in our community. And they popped up and were just like, hey, anyone interested in medications for opioid use disorder, thinking that they'd get like a handful of people interested or connected to the clinic. And they had a robust response. 47 people expressed interest in discussing meds. 35 people were like, today's the day, I'm ready to start. One went to a methadone clinic. 34 expressed interest in buprenorphine. One did, like changed their mind before getting to the clinic, or by the time they got to the clinic, they changed their mind. 2 people went directly to a monthly injection. I think both of them had recently been discharged from jail, so had sublingual bup kind of on board already. 3 decided to do sublingual buprenorphine, and then that 28 ended up doing this 3 day injection series, and 15 people ended up getting the monthly injection, which was very cool. And just to say, there's a lot of like research stuff that's happening in this space. This is our friends at UW-ADAI, which are doing this like data integration work, and now are doing an evaluation at like a population health level of like, does a subacute stabilization center, which has now become the ORCA Center, help impact medications and retention and morbidity and mortality and other things. And then we're also doing an evaluation for our ORCA pod team, so our outreach team, and looking at does intensive outreach either on the street or in permanent supportive housing and shelter make a difference, particularly in overdose frequency and medications. And yeah, there are like lots of things we're really interested in evaluating, and we're like setting up systems by which we can evaluate this more robustly. But we're super interested in like looking more at the 3 day LEI series and like retention rates, looking at pre-hospital buprenorphine and how those folks can and maybe should go on immediately to long-acting injectable formulations. We're starting methadone initiation and linkage. We're also using methadone during the 3 day LEI process. So, like, someone's like at day one, they're like on their first floor, and we had been telling folks to like continue using fentanyl in order to fully cover that receptor. A lot of folks come to us and are like, yeah, would love to, but I actually, one of the reasons why I'm here is because I've lost, like, I've run out of my supply, or I don't have money to purchase full opioid agonists. And in that setting, it's been really helpful to actually offer methadone during that process. So for the 72 hours, we can help kind of cover those receptors a little bit with methadone. And Star Center, which is the shelter that's just down the street that we can place folks who we want to continue to intensely outreach over a few days after discharge from the ORCA Center. So what impact does Star have on the care cascade? And then yeah, having an overdose response tracking system has been hugely beneficial to us as a system. Like, how is that working, and what is the efficacy of that? Yeah, so I just thank you for having the space to talk about this. Thank you to Health 9998 teams who are like integral to this work. This is them outside of the ORCA Center responding um, to patient care. So maybe I'll stop sharing. Sorry to like talk at you for so long, but thank you for the time. Yeah, happy to answer any questions. I don't know if anyone's put anything in the chat.
I would love to ask a question. My name's Emma. I'm a family medicine resident here in Texas. Wow, I'm like blown away. I'm jealous, number one. Our health system's very different here, as you can imagine. I do a lot of work with like the homeless population, street medicine, addiction medicine, and always brainstorming ways that we can improve access to our patients and obviously prevent overdose. Um, are there, like, do you have a list somewhere of the papers you guys have already published just for me to review and maybe bring to our team that we could just sit and think on?
Yeah, we only really have one paper that's
Oh,
out.
really?
We
Okay.
have several others in process as one.
I get it.
But I can drop one, and then one is like a pre-release, non-peer-reviewed yet paper, but I can put that in there. And then also, I think we have if you're interested in like our guidelines, we're in the midst of
Yes.
editing them. So there might be a newer version that hits the interwebs soon, but I can share that
That would
here.
be awesome. I'll put my email in the chat.
Awesome.
Thank you so much.
Of course. And I don't know, maybe I can also share that. I don't know if it's helpful to share that more broadly. I'm happy to email you to like to share it out if that's helpful or put it in the notes too.
Yeah, hey, I'm Dr. Meek. I'm from Western North Carolina. That was fantastic. I really appreciated it. I really appreciated the breakdown of the elevator analogy from top floor to bottom floor. That's really useful. Um, we have a pretty robust. We're in a very rural part of the country, and so we have a robust outreach program, specifically addressing MOUD, MAT. But it's rough because it's so spread out. And I would love to share this information with my colleagues. I just didn't know if is this slide deck available? That would be enormous.
Yeah, happy to share that. Maybe I'll maybe share some resources and
Yep.
CC whoever puts their email in the chat, but I can maybe make it like a Google Drive version
Yeah.
of this and share it with you guys.
Yeah. Thank you much.
Yeah, and I went to college at Davidson, just north of Charlotte, so the Western North Carolina.
Mooresville.
Yeah, 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 yeah. If there's
Right.
ever way to come back,
Yeah.
spin that in the
Cool.
ether.
Cool.
But yes, well, thank you so much for your work.
Yeah. Seth Curry territory.
Oh yeah, he was a year older than me. May or may not taken a nice bath with his ankle once.
Nice.
Yeah, totally. Yeah, that's like the peak of my existence, probably. I really peaked in 2008.
Hi there. Just wanted to add phenomenal. Like I'm an IM resident in Pittsburgh and just so inspiring to hear all of that work that you're doing. We've actually been experimenting with Brixadi inductions as well. So it's super exciting to see that that's already out there, that it's published, that it's working. I'm gonna send this paper to some of my colleagues straight after this. So thank you. I just was curious about the methadone in initiation that you guys are doing for the 72 hours. And like, how are you navigating that? Because my very limited understanding of the 72-hour rule was that you could do it from like an ED setting, but not from necessarily primary care. How have you kind of figured that all out from a legal point of view?
Yeah, and I'll share with you the document of where we kind of break down some of the specifics of what the CFR, which is the federal regulation. I can never remember with all the numbers and dashes or whatever, but that I was surprised, and I will not take credit for this. This is like my medical director, who's also the person who is also spearheading the 3-day LEI series, but that in the CFR, it just talks about narcotics use for opioid use disorder, opioid. Basically, like it doesn't specify methadone, just talks about narcotics. It talks about 72 hours, and it talks about the dispensation, not the prescription. So dispensation or administration, not prescription, um, and linkage to care. So under that purview, and Boston did something similar with like initiating people on methadone from a primary care setting. So, administering or dispensing that medication, not prescribing it through pharmacy, but from stock, be able to take that then and then linking to care with methadone. And like under that same description, one can use other full opioid agonists like narcotics to help with opioid withdrawal for up to 72 hours and linkage to care, which we're doing. It just happens to be linkage to care back to us with LEI BUP. Um, so yeah, but I can send along the document in which we kind of go through the details of some of that.
That would be awesome. Thank you. So are these people, are you giving them their 3-day supply when you're initiating them from your stock, or do they come back each day for daily dosing with the methadone?
Yeah, maybe we'll feel more like excited in a future state, but what we are doing now is for folks to come back each day for us to be able to
Okay.
dispense and administer it in clinic. Um, we also have other full opioid agonists that we use during this process too, Dilaudid. And we always administer that currently in clinic, kind of to help folks through that process. What can I say about that? Oh yeah, and I feel like generally, I know people are doing some really amazing things of like escalating doses of methadone pretty quickly. Our process is usually like 40 to 50 to start off with, and then Q3 hour 10 milligrams. So like we also have the luxury of some folks want to stick around with us for a while, and we'll like kind of escalate the dose during that day one. But we don't go past 60 usually on those 3 days, unless kind of directed by the OTP or methadone clinic we're working with. Maybe one day we'll get up to 80 or 90, like some people in inpatient do. But I think right now we're just kind of getting our feet underneath us.
Awesome. Thank you.
Of course.
So if anyone has any questions, you can go ahead and ask. But if that is it, I think we can end it here. And also, I did realize I forgot to ask, but I can also include your email in like the um post-webinar email that we send. So if that's okay, I can also include that in case people want to email you as well. But yeah, thank you for presenting. That was a really informational webinar. Um, and also thank you to everyone that came. Um, but yeah, have a good evening. Yes, there will be a recording, hopefully by tomorrow morning, but if not by evening, it will be there on our YouTube, which I will link in the email I send after this webinar. But yeah, thank you guys for coming. Have a good evening. Yeah, bye
Thank you.
everyone.